Okay, we'll go ahead and begin today's session. So welcome everyone, and thank you for joining the webinar today to discuss a new paradigm for AI in stroke and the real-world use of a full brain solution. My name is Lacey Costa. I'm the Director of Neurovascular Product Marketing here at Aidoc, and today's speaker is Dr. Rajesh Rangaswamy from Renown Health. I'll review a few housekeeping items before we get started. The session today is being recorded, and the recording will be sent out to all registrants after the call. So if you need to drop off early or you'd like to share this with a colleague, just look out for the inbox for the recording in your inbox in the next few days. Also, if there's any questions, feel free to share them in the Q&A box, and feel free to write them as we go, and we will address them at the end of the presentation. So if you're listening today, I probably don't need to tell you how stroke treatment has evolved significantly over recent years. We've seen progression in medical understanding and technology, advancements in endovascular procedures, infrastructure, and public awareness. All of these have played a crucial role in propelling stroke treatment forward. The evolution of stroke treatment reflects a journey from one of limited options for patients with poor clinical outcomes to one of better understanding and effective approaches for patients today. Ongoing research and innovations continue to shape the landscape of stroke care and offer hope for further improvements in outcomes and quality of life for patients affected by stroke. In just the last decade, we've seen stroke-related artificial intelligence evolve from mere image viewing and email communications to a fully mobile solution with high-performing algorithms and acute care coordination. In today's session, Dr. Rangaswamy will provide an overview of Aidoc's next-generation neuro AI that offers a comprehensive stroke solution for the full brain versus just M1 and ICA anterior circulation only. We will explore how Aidoc's always-on AI and radiology-driven workflow increases patient capture and the ability to find the unexpected. And most importantly, we'll discuss real-world experience and its impact on patients. It's my pleasure to introduce our speaker for today's webinar, Dr. Rajesh Rangaswamy. Dr. Rangaswamy has served as the medical director at Renown Health and for neurointerventional services since 2010. Renown Health is the only comprehensive stroke center in Northern Nevada, and he and his neurointerventional partner treat up to 150 strokes a year. So needless to say, Dr. Rangaswamy knows a thing or two about stroke treatment. So we're fortunate to have him with us today to share his story about why Renown has chosen Aidoc as their solution of choice for AI. So without further ado, I will turn the floor over to Dr. Rangaswamy. Welcome.
Good morning, everyone. My name is Raj Rangaswamy. I'm the medical director of neurointerventional service at Renown. And first of all, I would like to thank Aidoc for giving me the opportunity to talk about, the new technology change in the AI. And thank you for all, being with us. So today I'm going to, before going to the topic, I just want to make sure there is no equity ownership with Aidoc, and I'm just a consultant. And I will go through now a story and how I become a consultant later on. But I practice here, very close to Lake Tahoe, beautiful, and there's Reno, and that's my hospital. So today's agenda, that's we're going to go through a history of stroke treatments at Renown and the AI at Renown. And the main thing is why Renown Health changed from Rapid to VIS to Aidoc. There's there's a lot of the AI, good AI available, in a stroke world, but the main focus today is like why did we change? That's our main focus. So the history. So we started we started a stroke in the early 2000. We started IA thrombolytics, Mercy device, stent retrieval, and aspiration. And we are the only one CSC at Northern Nevada. We do around 150, and we're only 2 people. So we get like a 75 thrombectomy. So we get enough experience to talk about it, I believe. So we started using AI in I think 2015. The rapid is using the CTP and LVO triage, and to be honest with you, they did a wonderful job, and there's no negative about it. And Aidoc, the same time, I think early 2018. So I think they're like they approached our radiology department. So they got integrated into the radiology packs for other things, non-neuro, for aneurysms and PA and, those, the AI. And during that time, around like a 2022, WIS approached us and asking us to, change it to WIS. Their main pitch is the communication, because in the stroke and the acute stroke situation, the communication plays the major role, and they told they do better job than the rapid. So we actually Renown signed the contract. So around 2022 time, like I had like two softwares. One is rapid is already going in my cell phone, and CTP and LVO, and then WIS is also going, so I can compare both. Then Aidoc approached, because the Aidoc is already in our system packs and not in the neuro thing, but they approached us, me saying that we do LVO detection and all the whole neuro, and they asked for me for the meeting. And to be honest with you, and I'm skeptical. Why do we need the third, thing? Like it's going to do the same. So I just went to the meeting very, reluctantly, in the sense, like open-minded, but thinking that this may be the one of the, the other AI thing. But I was surprised with a few items. So that's what I'm going to share today. So when I went to the meeting, my first question to them is, it should be non-inferior, right? Like we don't want, this is doing great and rapid is doing great. Like it's detecting the LVO, 90% of the time. And yeah, and then, CTP is all good. Clinically, it's all fine. But, why do we have to change it? It has to be non-inferior. So that needs to be done. So I asked them to put, to give that app in my cell phone, and so I can compare. So within 30 minutes, I downloaded. It's all set up. Our IT department worked with the Aidoc IT department. Both are like great. And so they set me up for, the Aidoc app. So imagine I have 3 apps at the same time, like WIS, Rapid, and Aidoc in my cell phone. So I compared for a couple of days, like at least like 30-40 cases, comparing all 3, every stroke patients. I just compare all 3, and I found out there is no, not much significant difference between like a CTP analysis and LVO detection. Like you can see there, this is the Aidoc, and it's just same thing, like Tmax and Tmax, and all those things are there, and CTA and large vessel occlusion. And then, like I mentioned, the WIS is saying like a communication. That's why we changed from rapid to, we're trying to change. And then the communication piece, rapid, the Aidoc gives, it's there. Like here you can see, you can chat and call the people, and there's not much difference. So here, Aidoc is providing large vessel occlusion, and it is great on communication. So then what's the difference, right? Like what's the difference between a VIS and Aidoc? Why do I have to change? But that time they mentioned the Aidoc is identifies and the medium vessel occlusion. So that is the main, then I was skeptical, but then I want to look into it. And then the other thing, uh, uh, one main issue I want to go through is we have like 10 or 15 hospitals sending the images to us, the CTA images to Renown. So the middle of the night, I just wake up and then look at the image and go to the telerad, and we have a software like then look at the images, takes 10 minutes, and see if there is a large vessel occlusion, and then bring the patient. So I was asking, Rapid and this, what if they get this AI platform in their hospital? So if they do that, then it may be easier. So they tried. So it's not happening. That was the big, the point for me. Like they said, they're going to put the orchestrator, the device in the referral hospital, so they can analyze their CTA in the hospital, the scan itself, and then it can send the analyzed images to us and their radiologist for pretty much free. So then they can, if there is a large vessel occlusion, they can send. So that is one of the main reason that I was very interested in it. So then they said, and then they're working on it, and then I was analyzing the images, all the 30-40 cases, and then I found in the 30-40 cases not only a large vessel occlusion, and we could able to find a medium vessel occlusion. That's the, like they mentioned, like I can see in this image, M2 occlusion here, and we should able, the Aidoc able to identify it. So that's a big news. But then I asked Aidoc, okay, is it possible, because the nearby hospital, they're sending the images, right? Like the referral hospital sending the images to Renown. Is it possible to analyze those images using the Aidoc? And then Aidoc said, oh, absolutely. So right now, where they're able to, any CTA comes to Renown through our telerad or PowerShare, get analyzed with the Aidoc software. That's the huge. So the interesting thing is, like with Aidoc, working with the Aidoc is the wonderful experience. Like as a clinician, like, I'm looking for the patient, right? Like it doesn't matter whoever delivers whatever I want, that's what, we want. Because for me, the patient is the main person. Like Aidoc is like, I can reach them and then tell them and what I need and what, they just do it right away. So right now, and our the referral hospital's images getting analyzed. So let me tell you this story, a story in this context. So this patient, like 2 months ago, I think a 50, 60-year-old patient, the outside hospital radiologist, they read as M1 stenosis, NA stroke scale 15. And so the images came through. Our neurologist looked at it and kind of went with the radiologist report. So M1 stenosis, we're not going to, do in the middle of the night. And he told, okay, blood pressure and all those things, and not to bring the patient here. But I just woke up with with the alarm from the Aidoc, because the Aidoc analyzed it, and then Aidoc called a large vessel occlusion, M1 segment. And then I looked at it, images are there, and scroll through, I feel it's a large vessel occlusion. Then I called neurologist and bought the patient and did an angio, and sure enough, that's a large vessel occlusion. And I could able to remove the clot. So the patient from NIH 15 to 0, he walked out of the hospital. So that wouldn't have possible without that Aidoc analyzing the outside facility CTA, which came through our hospital and then analyzed. So for me, these 3 points, right, like identifying the medium vessel occlusion and ability to analyze the outside facility like a hub and spoke model, CTA, so we can have a better control. And even if this is, some hospitals may not like that concept, but they can send the images, but that still can analyze. So imagine like if the power share, Stellirad, and we go and sign in, and then just looking at the images, I'm sure you guys are doing the same thing. It takes like at least 10 minutes. But here in the middle of the night, I just look, my cell phone and scroll through it. And that's the huge change. So for me, from here, it's a no-brainer. Okay, then I told, I'm going with the Aidoc because this is not provided with other AI. And then the other surprising things, this is what, it may interest you, like the Epic integration. So right now, but this is the Aidoc app. So there's a small little thing called info. It's like, it's just red. If you press this, it opens up this window. So where the patient's information, the vital signs get integrated. So in the app, I can see the systolic blood pressure, diastolic blood pressure, SpO2, and all this thing. So imagine this patient with a ICH, and I can see, okay, blood pressure is 137, and then I can click this, the whole trend, every 5 minutes, whatever in the Epic, it's there. So within a seconds, I know what's the trend. I can call the ER telling that, okay, the blood pressure is high, and give this and that. Our neurologists love this thing because they can give the TPA, looking at all the contraindication here. That's the huge improvement. Not only that, the stroke, I'm asking them, this is work in progress. So what we're going to do is, they're going to put all the stroke metrics, because JACO, Joint Commission, needs that we need to look into ER to imaging time, ER to puncture time, ER to TK3 time, and MRI stroke scale, NH scale, and all those things, right? Like here, the Aidoc, they're going to get those information from the Epic and then put it in this app. So that, what's going to happen is that thing, it's going to change. So every month, I don't have to go and dig into Epic and every detail. Now, everything is available in the app itself. So that, again, I can't explain how happy. And even hospital, I feel they're spending like a lot of money, hiring people and to dig the data. Here we have the data. And the next day after thrombectomy, imagine like I have to go to the Epic and look for this detail, how the patient is doing. Here, I got all the information. Like I go and then look at the info. Okay, the NH stroke scale is improved or not improved, and all those things. So that's a huge change. This one, the PACS integration. So this is the main thing. When one of the main thing where like I had trouble with the other AI, because for some reason, maybe they're working on it. I believe the competitors because I was looking our radiologists. So this is what happened, and you guys may feel the same. Like right now, this AI softwares, like they get the images from the scanner itself, right? Like immediately it goes to the server, and I get the alert within minutes, like couple of minutes, right? The rapid does the same, this does the same, the Aidoc does the same, no difference. But, and then the technologists do their job and send the images to the PACS. It takes at least 10, 15 minutes. So by the time our radiologist, and the radiologist, like our radiologists know about large vessel occlusion, I already know it. Neurologists already know it. So it's just our radiologist feels they left out. They feel like, okay, what's the point? Like kind of they find they're not a team player. So I was telling them, because I don't want that thing to happen to our radiology colleagues, because JCO is looking, the other thing, JCO is looking at, how fast we read, right? Radiology read, like email report is coming. Like I was asking them, like, rapid, can you put it in can you integrate in the packs, or can we put into the somehow, in the desktop? But somehow they couldn't able to do it. They're working on it, and they're saying like, oh, you need to sign into the app. So our radiologists are not interested in it because they want, the workflow has to be within the packs. But the Aidoc, as I already mentioned, we already got the Aidoc and the other things like a PE and all those things. So when we got integrated into it, it's just a seamless, because the stroke is right now integrated into the packs. So they get an alert the same time I get the alert, and then they just stop whatever they're doing, open the study and report it, call the ER, so they feel the team player again. So that's a huge thing. So let me go through, these things. This is our workflow. So here you can see the small red box. You can put it in anywhere. You can move around in your specs, in our screen. So that is a thing. And this is our, Fuji Synapse list. And it's the priority. And here you can see the Aidoc, the red box. So what does it mean is, in the list, if there is an Aidoc, there is a finding, there is an alert. So that may be a large vessel, or it may be a PE, or it may be. So then, when you're doing the list, then you can go to that case, and then immediately, you can report, you can call the team. So let me go through this. This is the most interesting thing. Like, so when I I rarely read our ER list. And when I was reading in our busy list, and I get the CTA, the CTA head and neck and CT, like all three. No, it's just a lot of images, like 1,000+ images. It's kind of sometimes, oh, I need to go through this. But imagine, and this is what happens. If there is a positive, it just flashes it, it's just like then that means there is a large vessel. Here is this patient has a brain aneurysm, and it's a vascular occlusion, ICH, cervical spine fracture. The integration of the PACS interface is wonderful. So that's another thing why we changed it. So let's go to this next one. So, let's review again. The main thing is, able to identify the medium vessel occlusion, and, getting the system in the referral hospitals, the orchestrator. So that can be, the referral hospitals can have we can process those images that can be sent to us, and then referral hospital radiologists, we are working on it, able to analyze SAD, outside facility CTAs in Renown itself. That's the huge thing. Epic integration and the PACS integration. So that's why we changed. Let's go through a few case examples. Like here, 58-year-old woman fell on ice and small subdural, and some lateralizing neurodeficit, which was read normal. It's understandable. This tiny little thing, the history is not stroke, right? Like, maybe, we may not look at the vessels that carefully. So here, Aidoc is alerting medium vessel occlusion, then subsequent neuro intervention consultation. So that's, this type of things happens every day. So that's a huge thing. The other, 66 left-sided neurological deficit, CTA, subtle M2 branch, and, very small little things like that. And the other thing I want to tell, because sometimes, I'll be honest with you, sometimes the Aidoc, false alerts in the sense it may not be a true occlusion, it may be a stenosis. But it's not intended for that. So, but when you have it flagged and then you look at it, it's stenosis. So now I call the neurologist. Okay, it looks as stenosis. We are not doing anything, but can you keep them on dual antiplatelets? Can you keep them on high pressure, high, blood pressure management, fluids? Let's see what happens. So, finding the, as you guys know, finding the M3, M4 stenosis, it's not easy. If you look at it, you can find, but in the fast reading situation, it may be, easy to miss. So that's very, very helpful. So then beyond stroke here, it's not just a stroke. That's another thing. Like, the Aidoc is coming up, but, it's there. Like we are using it. Suspected aneurysm, ICH prioritization. That's there. And it is, posterior circulation, LVO, medium vessel occlusion, the midline septal algorithm they're coming up with. So then the complete radiology solution. So not just the neuro, not just, it's, the whole thing is there. I'm going to go through that thing in a minute. And then the care coordination, patient management, they're even looking at something like, getting the report analysis, for example, 3 or 4 millimeter aneurysm in the report, EPIC report, Aidoc can analyze the reports and then alert the clinician about the follow-up. Sometimes this thing can be missed. But last but not the least, they always ask for the feedback. Great support. So I mentioned, why I become a consultant. So it's not like, I do, the stroke is something is my passion. Like I took call 10 years in Renown without alone, like doing it because all my ideas to save someone, so that's my passion. And right now, as you guys know, we can remove the clot. The main problem our community is facing is how to bring that stroke patient to the room, right? That's the priority. So when I see the Aidoc is coming up with all those things, medium vessel occlusion, care coordination, this and that, and referral hospitals thing, and analyzing here, I feel the Aidoc is, doing something which is going to change the outcomes of a lot of stroke people in the country right now. So then I called, I want to be part of you guys. I want to mention this to the people, like who are interested in it. And then the first thing I asked, like, how many people are using this? And because I want, everyone to have this thing because it's going to change. So it's me calling them and asking them about this. And then they told, okay, Raj, and you can be a consultant and then, tell your experience. So that's how it happened. So I'm very, happy that that I'm part of the team, and the Aidoc is committed in the neuro space and establishing themselves as a market leader. So this is the this is the market. This is the slide I took it from them. So this is how they're doing, like diagnostic radiology space, stroke, hemorrhage, brain aneurysm, C-spine, vertebral compression fractures, midline sept, like a lot of things, PE, incidental embolism, aortic dissection, valve measurement, coronary arterial calcification, rib fractures, free gas, lung nodules, breast, a lot, pneumothorax, ETT, malposition, osteoporosis, a lot of things happening, right? In the stroke world, again, the same thing I mentioned here. And, this lot of things, in radiology. So I think AI is very exciting. And because of the AI, I strongly believe, the stroke, with technology, we already reached, we can remove the clot. The issue is how to bring the patient in the room. I think Aidoc is going to help, and we're going to change the outcomes of lots and lots of people. Thank you very much, and let's open to the question and answer session.
Thank you, Dr. Rangaswamy, for that presentation. That was really, really great. To the audience now, if you have questions, please feel free to put them in the Q&A box, and we will go through as many as we can in the time that we have left. Again, great presentation. We really appreciate all your efforts you put into that, and we also enjoy collaborating and partnering with you. So wonderful. And maybe I'll start us off with a question, just to kind of get us going here. So if you had a piece of advice for anyone looking to champion neuro AI in their hospital or institution, what advice, what would you give them?
The advice, if you are already using it, something else, some other, so just compare, yourself. That's what I did. Just get the app in your system and then just compare it. Then you will find the difference. There is no doubt about it. But, the one thing is listening to people. Like, I'm just being honest. Like, the other thing is just compare. And you get the app and compare, and you'll find the difference. And if you don't have any AI, just get that app and keep it going, because it's going to change the way, and the time is brain, and it will even 10-15 minutes or 30 minutes change is the huge. And then the app, it's, to be honest with you, it's like a car, and it's those, if you know how to drive one, that thing is going to be the same. Something is better than the other, but there is not much learning curve. And the main thing is the large vessel occlusion communication piece is already there, but I feel the Aidoc is giving lots and lot of more, like I mentioned. So I think you need to experience it to understand its fullest ability. So just get the app, and that's my advice.
Thank you. Okay, I have another question that came in. The question is, does Aidoc have other packages such as ICH and aneurysm analysis? I can give a quick answer, and then I'll let you speak, Dr. Raj, to your experience with using any of the other solutions. But the answer is yes, we do have ICH from an AI standpoint. So we alert on ICH just like we do for vessel occlusions, and then also for brain aneurysms as well. So brain aneurysms, we have an AI algorithm that alerts on brain aneurysms in the radiology widget. And then we also provide a patient management solution with brain aneurysms. So we do have a pretty comprehensive solution on both of those pieces. And Dr. Raj, I'll let you speak to any of your experience with the ICH or the aneurysm analysis.
Yes. So I'm still sharing, right? Can I go back to the slide? Or,
Absolutely, yeah.
So this is the slide. If you look at it, that's the intracranial hemorrhage. So here, like in a neuro, like a stroke, LBO, medium vessel occlusion, CT perfusion, intracranial hemorrhage is there, midline sepт, brain aneurysm, C-spine fracture. So yeah, it's everything is there. And actually, this patient I was showing, that's intracranial hemorrhage get alerted, and then I mentioned the small little tiny subarachnoid hemorrhage get, so ICH and aneurysm and medium vessel occlusion, those things are all there, and it's a game changer.
Great. Okay, let me just take one more question here. Let's see here. There's a question on whether or not we do SPECT, and then if we have ischemic penumbra and core progression with stroke. So we do have CTP. That is in our stroke solution. So CTP, yes, we do. SPECT, no, not to my knowledge, but that is the answer there. Raj, maybe if you could comment about CTP and your experience there.
Yeah, the CTP, that's how the whole thing started, like a CTP, the T-max. Let me go through the slide right here. Okay, so I think I missed this slide. So that's good, like stroke workflow. So this is what we get an alert, right? Like an alert suspected LVO. And, the activation, we can activate using the communication piece. So that's a non-contrast CT. Then the CTA, large vessel occlusion. It shows exactly, you can go through that. And then here is the CTP, like a CPV, CPF, mean transient time, and Tmax, and everything will come. And then it will tell, like, what is the Tmax and what's the CBV less than 30%. And here the information phase and then activation. So the CTP is there. And actually this right now, you can see this particular patient, the Tmax is more than 60 seconds and RBF is less than 30%. It's 0. That means there's nothing there. There is no ischemic penumbra, infarct here, and then just a Tmax more than 6 seconds. There is no ischemia. So this patient is a normal patient. So that's the CTP piece is there, and then this is CTA, and that's a communication.
Thanks, Dr. Raj. I'm just looking here on a couple of questions. While I'm looking through these, maybe one question I'm curious is for incidental findings. Do you have experience on incidental findings for brain aneurysms with our solution or with others? And what's your experience been there?
Yeah, absolutely. Because when you're reading a CTA for something else, like a numbness or even like today, actually, yesterday night, there was a patient, 47-year-old, and came with a stroke symptom, and there's a tiny little M2 aneurysm. So it's radiologists get alerted, and it's easy to miss. And imagine you're thinking about large vessel occlusion, and then it's easy to miss a tiny little aneurysm, right? Like that. So it's not like we're going to do something with that, but at least it depends. If the family history, 3 millimeter PCOM, and that's a different deal versus 90-year-old with a 3 millimeter some ICA aneurysm. But at least knowing it makes the difference. And then the other thing, like I mentioned, it feels, it's confidence. Like even though we're looking, it gives you a confidence that okay, the Aidoc is, if it is not there, and most likely you're not going to find it. So that's you feel like some resident or someone is looking for you.
Great, thank you. We have time for a couple of more. Let's see here. I just want to clarify one thing on our indication, because there's a question in the chat, and I just want to make sure I clarify our indication for vessel occlusion and what we're indicated for. So Aidoc VO, we're indicated to assist hospital networks and trained medical specialists in workflow triage by flagging and communication of suspected findings of complete LVO, basilar, medium vessel occlusions, and I won't list all of the vessels, but the one thing I wanted to make sure that we just make clear is that our notifications, they include a compressed preview image, and they're meant for informational purposes only. They're not intended for diagnostic use beyond our notification. So our notifications go to Dr. Raj, and then of course he makes the diagnosis. So there are notifications. And our device also doesn't alter the medical image in any way. And just wanted to clarify that. And that was a question in the chat on our indication. So that's that one. And... okay, wonderful. So how about this next one? In terms of a learning curve, what kind of learning curve have you experienced? You know, you've used Rapid, you've used Viz, and now Aidoc. What's your learning curve been with the different solutions?
To be honest with you, is nothing. Like it's just like if you know one and it is within 2-3 minutes, it's all, to be honest, it's all looking the same. Like and the same in the sense, the continual improvement. Like it's hard to, because I was using Rapid and 5 years ago, and then Viz, and now I'm not using. So I'm sure they come up with something new and something interesting, like because I don't know, so I should not tell like Aidoc is the best interface and this and that. I'm not going to tell, but there is no learning curve at all. Like you just open it and then it's just there, and then you click it, and then you just look at CTA. You can scroll through up and down axial images, and then sagittal coronal and those. And then recently I've been noticing, I look at the CTA aspects, right? The CTA aspect. So you can open the CTA image and then change the window, like an aspect window or brain window, just it looks, and then you can see the perfusion on the CTA, not the CT perfusion, which has been done dedicated. But this is just a CTA. So you can aspect score, you can change the window, and then you can just zoom it. It's just pretty much simple, and there is no learning curve. Not just because of Aidoc. I don't think even like Rapid and Viz, and they're all like the same.
Great. Thanks, Dr. Raj. So I think that is pretty much all the questions I have in the chat right now. That addresses everything that I have. If anyone has a last minute question, feel free to type it in. Otherwise, I definitely want to say thank you again to Dr. Raj for all the information today. Again, we did record the session, so we will have this available to all the participants in the next few days. And I think we'll go ahead and conclude today's session. Dr. Raj, any last parting words from you?
I think I spoke a lot. I think, yeah. So the last thing, thank you for whatever you guys are doing. I think it's wonderful to see the AI changing the the outcomes of the stroke people. So I wish you guys do more and more and more, and then we will reduce. Like I don't want to see my whole dream is I don't want to read the MRI with a huge large infarct. So that means we are finding those people soon enough, bring the patient to the room and do the thrombectomy, and never see that large infarct again. That's my dream. So, but you guys are helping me to achieve the dream. Thank you.
Thank you so much, Dr. Raj. All right, well, we'll go ahead and sign off for today. And thank you everyone for your time on the call today. And we look forward to the next one. Bye for now.